tuberculosis in Honduras. So what I tried to do is I want to speak in English, but my slides are in Spanish. I don't know how it's going to work, but we'll see. So we're trying to do multilingual. And I use Google Translate, so sometimes some of the wording is not quite right in Spanish, but bear with me and I'll try to explain what I mean. So, I am Janice Louie and I'm an infectious disease doctor. So I do tuberculosis at home in San Francisco, California. So what is tuberculosis? It's a bacteria that primarily affects the lungs. I think we all know that. It's actually a fairly severe disease. So it's one of the top 10 causes of mortality and morbidity, primarily pneumonia in the world. And it's estimated about 10 million people are infected with TB, and about 2 million or 20% die due to TB worldwide. More than 95% of the deaths occur in countries like this, where we are considered more of a developing or resource-poor setting compared to the US or Europe. And HIV is a major factor for death in persons with TB. So in Honduras, we have about 3,000 cases reported annually. So it's a reportable disease. If you diagnose it, you have to tell the government about it because there's a lot of action that surrounds treating TB. Honduras is number 95 among 211 countries in the world where they monitor TB, so it's not high up. The countries with most TB are South Africa, China, Philippines, Vietnam, and Russia. I got this from a website where it said TB is most common in San Pedro Sula, Islas de la Bahia y Gracias a Dios. I think that's a place, I'm not sure, but yes, okay. And 10% of patients with TB in Honduras also have HIV. So how do patients get tuberculosis? Well, it usually starts with someone who's coughing. And that person can look perfectly healthy. And I tell my patients at home it can be someone who you were sitting next to on a bus or in a park or movie theater. So no one is at fault. But for whatever reason, someone coughing has TB in their cough. We call it droplet nuclei. And those droplets go into that person's lungs. They go down deep into the pulmonary alveoli, which is the sacs at the bottom, and then they start to multiply. And then the TB can either stay in the lungs, but there's always some period of bacteremia where the TB is spreading throughout the body. And it can spread to other places where it can also start to set up and multiply, like the bones, the spine, lymph nodes like in the neck, in the brain, in the kidneys. Those are the common places where we see extrapulmonary TB. So there are two stages of TB that are important to know. There's latent TB and there's active TB, okay? So in latent TB, if a person is young and healthy and they have a good immune system, what happens is they get the TB infection in their lungs and it goes throughout their body, but they have good immunity. So the immune cells wall off the TB and it forms what's called a granuloma. And these persons are considered to have latent TB. They're not infectious. They have a normal chest x-ray, but their PPD is positive, their skin test, okay? And this is typically someone who, again, feels fine. They may have felt a little bit ill when they got infected, but their own immunity walled off the infection, and now the infection is dormant in their body. So those persons, they do pretty well. If they're not treated, over their lifetime, they have about a 5 to 10% risk of the dormant TB becoming active in their lungs. So that's, if you're 10, that's very low. You can treat that latent TB or dormant TB with medications anywhere between 6 and 9 months of treatment with isoniazid or rifampin. However, there are some people who, if they have latent TB that's sleeping in their body, they are at higher risk of it reactivating and developing pulmonary TB. And those are persons with HIV, where their risk is 10% per year of developing active TB if they're infected. But also people with diabetes, or who are old, or who have poor nutrition. So for example, in the US, many of the patients I see are 85. So they were infected when they were young. They came from China or Vietnam or Philippines or Guatemala or Honduras. They get to the States, they do fine, but they hit their 60s or 70s. maybe they have diabetes and suddenly they're coughing and they're losing weight and they're diagnosed with TB that reactivated because their immune system became less strong over time. So active TB is when the TB goes into the lungs and starts to cause destruction, and multiplication of the bacteria is unchecked. So you have cavities that form with holes full of pus and lots of bacteria that are TB. So when a person's coughing, if they have the cavities that are full of TB, there's lots of TB in that cough. Okay? So as I mentioned, it can also go to the lymph nodes. So we see patients with neck TB or lymphanginitis or scrofula. In the back, it's called Pott's disease. The joints, the kidneys, other places. Before we had medications, the mortality with TB that was not treated was around 50%. So back in the 40s and 50s, in many places they would put people with TB in a special sanatorium, and the cure was sunlight. And most of those patients, about half of them would die because we just didn't have medications prior to the 1950s. So transmission, as I mentioned, is someone is coughing. And what we in the U.S. call droplet nuclei. And so they cough, and they're small and they're suspended, they hang in the air. They can hang in the air for as much as 4 hours. So TB is considered very infectious. I don't know if we have N95 masks here, but the way we protect, if you see someone who you suspect has TB, Peggy says yes, is you wear an N95 mask because that prevents those small bacilli in the air from going into your lungs. You cannot spread TB by touch. So if the patient has lymph node TB or TB of the spine, if they're not coughing, they're not infectious. It's really the cough or the sneeze. Sometimes TB is spread by singers. Those are the people who are most at risk for transmitting TB. In the States, not to always refer to the States, but that's my experience. Sometimes we have people who have kind of a hoarse voice, or they're coughing and we're not sure it's TB. And we send them either to a pulmonologist, a lung doctor to have a bronchoscopy, or an ENT doctor like you have here to look at their throat. And that is a very high risk for them getting TB. So they get very upset at us. So we always make sure we rule out TB before we say, we're not sure if this is laryngitis or if this is something. We always make sure there's no TB before we send them to be scoped, because that is a very high risk procedure. So this picture just shows that one person can infect 10 people within a year if they're not treated. So it's a very transmissible disease. It's why it's considered a public health problem. Okay, so I think everyone knows the symptoms: weight loss, cough, night sweats, coughing up blood, loss of appetite. I think the key here is that it's really a disease that's chronic, so over months. So 1, 2, 3 months. It's not going to be a disease where you have, like the flu season, 5 days or 10 days of cough. It's going to be 3 months, 4 months, okay? And they look pretty sick with TB over time. So in children, it's much harder to diagnose TB because their symptoms are not as specific. So they might have cough, but sometimes they look actually pretty good. Sometimes they might say, the mom might say they're losing a little bit of weight, or they're not developing on the growth scale, or they don't want to play as much, or they're not sleeping well. But it's really much more subtle than the classic picture. So it's much harder for pediatricians, I think, to diagnose TB. Children are more likely to have extrapulmonary TB, so they may be more likely to have it in the neck or lymph node. If they're under 5 years of age, they're at high risk for developing severe disseminated TB, so that we call that miliary TB, so throughout the body or in the brain. And mortality is very high. So that's why in every country except the US, babies get a BCG vaccine at birth, because that prevents complicated TB up to age 5, more or less. But it does not protect you from severe disease as you get older. It lasts more or less 5 years, okay? The other problem with kids is that it's difficult for them to get them to cough up sputum. So they can't follow the instructions very well. Often it's more spit or saliva than deep sputum. So it's really tough. You know, pediatricians have a hard time with TB. X-ray is not always typical, so it takes a very good clinician to diagnose TB in children. So how do you diagnose TB? So the classic is the X-ray has infiltrates or pneumonia in the upper lobes of the lungs. TB likes to live where there's a little more oxygen up above. And you see this hole there. The classic is that cavity. Okay, so that cavity is filled with pus, full of TB. So those patients are very infectious. We really are very careful with making sure they are isolated, wearing a mask, get on treatment right away. You also need to make sure it's TB though, because many things can cause a cavity in the lungs, so you have to get sputum. So the sputum is once a day. The morning sputum is best for 3 days, because what we do is an AFB smear, so that's this little thing here. These are, these pink little, we call them red snappers. Those are TB organisms by smear, okay? But each sputum is only about 50% sensitive. So you get 3 on 3 days. That gets you up to about 85% sensitivity. But the gold standard, this petrol or I'm not sure that's the right word, is culture. So the sputum smear takes 1 or 2 days. I'm sure we don't do much here, but they do it a lot, I think, in the main hospital. And the culture takes up to 8 weeks. So what we tell all our doctors and nurses, if you see a patient who you think has TB with the symptoms, even though the smear is negative, it's not that sensitive, you should still worry about TB. You should still wear a mask and treat them accordingly until the culture comes back soon enough, for sure. So the treatment of TB is very complicated, but the good news is that TB is curable if the patient can take all the medications for as long as they're supposed to take them. The problem is they have to take up to 12 pills a day for between 6 to 18 months. So that's really hard to get patients to do, especially if they're already feeling sick. They get nauseated, there's a lot of side effects. We have 4 main drugs that we've had for decades. TB is not high on the list of diseases that pharmaceutical companies want to develop new medications for, because it doesn't affect first world countries as much as it does developing countries. So, you know, if you are in the US, they would rather put their money in medications that they can make a lot of money off of, that you take for your whole life, like depression, like gastritis, like the statins. Those medications are for life, and they can be expensive, and they make drug companies a better profit than for TB. So we have only old drugs that we use. And I think in most cases, and for some patients, again, the ones with HIV or cavities or extensive disease, sometimes we go out to 18 months because we really want to make sure every organism is dead. So we are worried about that because resistance is becoming a big problem. And in Honduras, about between 2 and 12% of patients diagnosed with TB have multi-drug resistance. So resistance is when there's some residual bug after treatment that becomes resistant. It's exposed to the medication, but it's not completely dead. And when you have resistance, then you start having to use new medications, including injections, daily injections, medications that cause a lot of side effects, vomiting, depression. You're looking at 2 years or more of treatment. That's a long time. It's really a life-changing event for many people to be diagnosed with multi-drug resistant TB. They have to give up their jobs, they have to stop going to school, they have to focus only on their treatment. And in the most difficult cases, even if they're on treatment, mortality is as high as 50%. Do you remember in the news there was this lawyer who was on an airplane, maybe you guys are too young, but maybe 6 years ago, there's a lawyer who had very resistant TB who got on an airplane, and it caused a huge public health crisis. And the reason everyone was so scared because the mortality is so high, and he was coughing on this airplane, and so there was a big to-do. Anyway, as I mentioned, 2 to 12% in Honduras have some type of resistance to TB. So when we diagnose a patient with TB, we start treatment, we take care of ourselves with a mask, but we also have to report to the government, because there is a whole team of health workers who work for the government who do directly observed therapy, which is the standard recommended by WHO. And what they do is go out in the community every day and watch the patient take their medication. And that can be for 6 months, 9 months, 12 months, or longer, to make sure that treatment is completed, to make sure that the medications are not being thrown up, to make sure that the patient is following all the right instructions to ensure that their family is tested as well, to make sure they don't have TB. All to make sure if you identify TB, you completely cure it, so that you don't worry about resistance. So that is now the standard. In the US, we also actually have, you can download an app on your phone, and we give it to the patient so that they record on their phone, and then we can monitor it remotely. So hopefully at some point that comes to Honduras as well. We're a little bit off from that, but you know, as many people have phones nowadays, so there are ways to make it less labor intensive, but for now it's very labor intensive. So here's just some misconceptions about TB that I found that may be specific for Honduras, but it also applies to the US. So patients with TB are often very stigmatized, and in Honduras, and maybe they're also perceived as having lost their values or ethics or being, you know, less desirable in the society. So we know that's not true, but we have to be aware of that when we take care of TB patients. You have to be supportive psychosocially as well as medically. Many patients believe if you only treat the cough, that you're treating TB. So they'll go to a pharmacist and get cough medicine, not really realizing that this is an infection that requires a lot of medication. So we have to be aware or educate patients if they have a cough, if they have TB. Treating the cough does not treat the infection. And TB is not caused by things like walking in the rain if you have a fever, or working in the factories where there's a lot of dust, cigarette smoking, or sharing utensils. These are some things that people believe cause TB transmission, but really it's, as I explained before, it's sitting next to someone who's coughing and had TB. Okay, so in conclusion, TB is a serious infection of the lungs that can cause death if untreated. You should always think about TB in these patients with chronic symptoms, so cough, fever, weight loss, night sweats, losing appetite, and it's over months. You know, it's not just a week or 10 days like a virus, it's several months of these symptoms. Especially worry about it if you have a patient with HIV or uncontrolled diabetes, or they've been exposed to someone who is already diagnosed with TB. You have to diagnose TB with an X-ray and the sputum studies. There's no other way to go around it. And if your suspicion is very high, even if the smear is negative, you treat until the culture comes back, just because the initial smear is not very sensitive. We also try, when we can, to treat latent TB, so that's a positive PPE test, but a negative X-ray, because that is the reservoir. When they become active, those are who are infecting new people, and so we try and eradicate TB by treating those who have the dormant infection. Okay, that's it. I'm glad it only took 10 minutes. So are there any questions about tuberculosis? In the US, less so in Honduras, we can ask the doctors here. My understanding is TB is mostly treated at the hospital, and they have a high caseload, according to Dr. Ashley. Many of them have HIV. So you may not see it here in the clinic, but in order to protect yourself, too, if you have suspicion for a patient with TB, because they come in with these symptoms, put on a mask and just have a high sense of testing if you think, or sending them to the hospital if you think they might have TB.